Many clinicians enter the correctional system under the assumption that they are simply practicing community psychiatry in an unusual setting. In reality, prisons exist primarily to punish, deter, and incapacitate. When the clinical mission of healing meets this custodial mission, the two mandates grind together. This friction creates the dual loyalty problem, a structural pressure to prioritize institutional interests, like security, cost, and throughput, over the welfare of the patient. The WMA Declaration of Tokyo and other international standards set a firm ethical baseline. The physician's primary loyalty must remain with the patient, regardless of who signs the paycheck. Maintaining that loyalty is difficult when operational requirements constantly impede treatment. Security searches of medical records and mandatory reporting of session disclosures create a persistent conflict with therapeutic confidentiality. If a psychiatrist fails to validate this tension, they risk causing iatrogenic harm, allowing clinical authority to be weaponized by the institution as a means of controlling the population. To function in this environment, a master correctional psychiatrist engineers a distinct ethical firewall, ensuring the medical enterprise never becomes a tool for institutional punishment. Psychiatry in prison is the result of an 18th century shift toward the rehabilitative ideal, creating intellectual space for medicine inside penal systems. Today, international frameworks mandate the equivalence of care principle. Prisoners must receive medical treatment of the same standard available in the free community. In India, these modern clinical mandates exist alongside the Prisons Act of 1894, a colonial-era statute with minimal healthcare provisions that still governs the custodial environment. This results in a massive gap between legal rights and practical reality. The Mental Health Care Act of 2017 grants prisoners advanced protections, including capacity-based consent and advanced directives, yet the infrastructure to support these rights is missing. The primary obstacle is overcrowding. While Indian prisons have a capacity for 400,000 people, occupancy rates routinely exceed 118%, swelling over 300% in some districts. Here, approximately 89% of prisoners with mental disorders are left completely untreated. Overcrowding is more than a logistical failure. It is an environmental pathogen. It directly drives sleep deprivation, violence, and the rapid deterioration of psychiatric stability. Under these conditions, equivalence of care remains a legal fiction. The clinician is forced into a role of pragmatic triage, focusing on immediate stabilization rather than the full scope of community standard care. The most frequent ethical stress tests involve the control and flow of clinical information. There is a legitimate flow of data. Psychiatrists share functional risk information to prevent self-harm, usually with the patient's knowledge. However, institutions often attempt to extract raw trauma disclosures for disciplinary hearings, requests the clinician must block. Weaponizing a safety plan to challenge a prisoner's credibility during an investigation destroys the therapeutic relationship, ensuring the patient never discloses vulnerabilities again. Clinicians must also distinguish between assessing fitness for adjudication, measuring the functional capacity to understand a hearing, and fitness for segregation. Because solitary confinement is documented to induce and worsen psychiatric symptoms, a master clinician refuses to certify a patient as fit for isolation, as doing so medically endorses a harmful custodial measure. The ultimate collision of medicine and security occurs during a hunger strike. The clinician must respect a competent prisoner's capacity to refuse nourishment, while the institution faces immense pressure to authorize force-feeding to avoid political fallout. By refusing to certify punitive measures and guarding clinical data, the psychiatrist forces the institution to take full ownership of its disciplinary actions, rather than hiding behind a medical seal of approval. Maintaining an independent clinical identity is essential for building a therapeutic relationship with a population that has been historically marginalized and abused. The therapeutic relationship in prison defaults to deep distrust because of the power differential. Patients view any authority figure as part of the security apparatus. To counter this, the clinician utilizes spatial separation. Meetings occur in clinical spaces, represented here in warm white, rather than in cells or custodial wings. Behavioral separation is equally important. The clinician actively avoids wearing institutional uniforms or any visual markers that align them with the guards. They maintain this distinction through language, using clinical terminology instead of the disciplinary jargon favored by security staff. From the first encounter, the psychiatrist provides a scripted explanation of the exact limits of confidentiality, creating an environment of honest, albeit limited, transparency. This boundary setting manufactures a safe therapeutic container inside an architecture designed for total surveillance. Solving these challenges requires moving from individual ethics to systemic, population-level strategies. In India, the greatest need is found among under-trials, people awaiting trial who make up 66% of the total prison population. Despite their vulnerability, these individuals are often excluded from rehabilitative programming, which is typically reserved for convicted inmates. To address this, clinicians use the risk-need-responsivity model to allocate resources where they are most effective. The R&R model targets dynamic criminogenic needs, such as antisocial attitudes and substance use, alongside standard symptom management to lower the probability of future offending. This is supported by trauma-informed care, which encourages staff to view disruptive behavior as a trauma response rather than a disciplinary infraction. Operationally, facilities require a stepped care model that includes primary care, residential crisis units, and access to secure hospitals when needs exceed the prison's capacity. The system currently suffers from a lack of liaison between prisons and district mental health programs, preventing a smooth transition of care upon release. Without through-the-gate planning, including housing support and a bridge of medication, released patients face a cliff edge that often leads to immediate crisis. Meaningful clinical gains made during a sentence require a permanent tether to pretrial diversion and structured community reintegration. Without them, the cycle of incarceration remains unbroken. The tension between custodial order and clinical healing is an inherent part of the correctional environment. A master clinician does not surrender to the security apparatus. Instead, they act as an independent medical firewall, preserving the integrity of treatment within the walls of the prison. The profession demands a dual mandate, providing complex psychopharmacology to the multiply morbid, while simultaneously advocating for systemic policy reform. Clinicians must actively challenge the therapeutic nihilism that labels these patients as untreatable, using R&R adapted interventions to achieve functional recovery. Providing uncompromised R&R-based psychiatric care is a legally binding constitutional and human right, independent of custodial status or behavior. Correctional psychiatry is the ultimate pressure test of medical ethics, requiring the constant defense of human dignity inside an architecture designed to strip it away.